This episode is brought to you by our sponsor, the American Academy of Orthokeratology and Myopia Control, which is currently introducing its new base membership. What is base membership? Well, it's the AAOMC's new free introductory membership type, designed to help educate doctors on myopia control and orthokeratology. Whether you are brand new, an experienced fitter searching for pearls, or someone who's dabbled in the past and ready to step up their game, AAOMC base membership can help, and it's free. So what do you have to lose? Go to Orthok.academy.com, click on the practitioner button, and join us. Join the war against the myopia epidemic. Welcome back to the Corrected View podcast. For our episode today, I have with us a regular co-host and president of the American Academy of Orthokeratology and Myopia Control, Paul Levine. Welcome back to the program.
Thank you, Matt. Love to do it. I'm happy to be on board, and thank you for putting this together once again.
My pleasure. And our guest today is none other than Dr. Bruce Koffler, an ophthalmologist and a board member on the AAOMC. Bruce, welcome to the program.
Thank you, Matt. I'm also pleased to be here and honored to give the ophthalmologist view on Ortho-k.
That's why we have him on. So Paul and I had talked initially about getting the ophthalmologist view on Ortho-k, and so I figured I'd just hand it right over to Paul and let him start us off. So, Paul, the floor is yours.
Thank you very much, Matt. Will do. I think that I'd like to start by just again thanking both of you, Bruce especially. Thank you for taking some time to do this with us. I think this should be a really interesting conversation. You know, globally, ophthalmology really dominates a lot of the Ortho-k and myopia control space, but in the United States, you know, a lot of it is the domain of the optometrist, and I think that a lot of optometrists think that ophthalmologists don't like Ortho-k, don't deal with myopia control, perhaps even disparage it. Of course, some of our own ranks of optometrists do the same. Bruce, would you just describe a little bit about your practice and your passion for Ortho-k, myopia control, and maybe enlighten us a little bit on what the ophthalmology circles are really talking about with respect to these topics?
Sure, Paul. It's really my, I guess, my life in ophthalmology has been a career of almost getting close to 40 years, and I was trained at Georgetown University School of Medicine, and then went to Georgetown University Center for Sight for my residency in ophthalmology and then fellowship in cornea and external disease. And I was very, very fortunate to, in that fellowship year, to work with Dr. Michael Lemp, who was a mainstay in contact lenses and dry eye on the East Coast. So I got really introduced to contact lenses in really a very highly specialized way. And when I came to Kentucky to start my career at the University of Kentucky School of Medicine, and then later on moved into the community to my own private practice, I introduced in my private practice a kind of a joint symbiotic relationship with an excellent contact lens fitter who continued to work with me in fitting our corneal transplant patients and other specialty lenses for corneal scars and other diseases that required lenses. So we did everything from hard contact lenses to soft contact lenses, and I guess I went to a few meetings and again was somewhat fortunate to get picked by the CLAO organization, which is an acronym standing for the Contact Lens Association of Ophthalmologists. And that organization is made up of people like myself who kind of are the unusual ophthalmologists that are very dedicated to practice contact lenses within in our field, in our area, within our offices. And I was picked to be on the board there and ended up several years later becoming president of that organization, and then now actually continue to serve the CLAO organization, which has been renamed to Eye and Contact Lens Association, the ECLA, and I serve it as the international chair. So I guess I've been just very fortunate to be involved. In the 70s, I did some corneal shaping of post-RK patients. I was doing some radial keratotomy in my office, and there were some patients who didn't get full correction, so I utilized contact lenses, and these were not the same kinds of contact lenses that we use now with reverse geometry, but they simulated reverse geometry lenses the best that we could at the time, and I showed that we could remold radial keratotomy patients and achieve additional correction without doing additional surgery. And a number of articles were written on that. So I was very involved with the so-called molding kind of concepts. And this kind of perked my interest when I heard about corneal refractive therapy. In fact, particularly when it was fully approved by the FDA for Paragon Vision Sciences in terms of overnight wear and the use in myopia. So we immediately started an Ortho-k program in 2002 at my office. So I've been doing orthokeratology since 2002 and really kind of started myopia control probably around 2008, 2009. And so I'm sorry, it was a long-winded answer to your question, but it kind of gives you some idea that there are not a lot of ophthalmologists that are terribly involved in orthokeratology and or even involved in sophisticated contact lens work. However, there are a lot of cornea specialists, and if they're not doing it in-house, they may be bringing some expertise in-house or utilizing other eye care professionals on the outside to do their, specialty contact lens fitting in special cases such as post-corneal transplantation.
Mm-hmm. Yeah, that's fascinating. Really cool history how you went through all that, and again, just for the audience's benefit, for those that don't know you, you're in addition to what you just described, you're still, or at least up until recently, been still cataract surgery, LASIK surgery, those types of surgical procedures that you've made a career out of.
Yes, I guess I believe in diversification in my practice. So I was somewhat fortunate to have good hands and ended up having good results surgically. So I did cataract surgery, corneal surgery, LASIK surgery, and I guess my career has been very diverse in a lot of different areas.
Mm-hmm. There's sometimes we practitioners, it's not uncommon maybe for a patient to come in for an evaluation, that the parents bring the child for an evaluation. We maybe recommend Ortho-k or even a soft lens treatment. And sometimes people will go back for a second opinion, or they'll go see their own family optometrist or ophthalmologist. And every now and then they come back to us with I went back to my old doctor who told me that was unsafe and I shouldn't do that for my child, and it's wrong. And we know that that's not true, especially if you're a pro and you know what you're doing. We all know how successful and how safe these procedures can be. How do you go about, what's the best way to educate the parents that maybe they did not get the most up-to-date information? And what's the best way to educate the doctor that might be disparaging some of these treatment options, in your opinion?
Well, I think for the parents, the best thing really is to be prepared with materials that they can read and understand. And I think that there are plenty of pieces out there in the literature. I've written several. Several have been used by many members of the AAOMC, and they have sent me emails complimenting me and the fact that they have used these for years. So to have a nice little packet available and say, please, let's read this. Here's some information from other ophthalmologists really involved in the field, and also optometrists who are really involved in the field, and you should really get the other side of the coin here. In regards to practitioners, and we should talk a little bit about this a little bit more extensively, I think that we should always look at opportunities where the glass is half full and not half empty, and not get very angry at some of the people out there who jump to their own conclusions, understanding that perhaps those, particularly ophthalmologists, let's say, spend their day seeing a lot of pathology, seeing a lot of disease, particularly ulceration with contact lenses, and they may not be too excited about orthokeratology, but they're probably not too excited about contact lenses in general, particularly extended wear contact lenses. So they have formed their own kinds of opinions, and a lot of their institutions, also their attendings, have kind of taught in that direction. Now things are changing, and the whole viewpoints that we see from the American Academy of Ophthalmology, from the Eye and Contact Lens Association, are more and more symposium and writings about how to deal with myopia. And in all of that, including the preferred physician patent program by the American Academy of Ophthalmology, includes orthokeratology in that section, where it is definitely one of the options in which a practitioner should consider in dealing with myopia. So I think things are changing. I think you can find this change in the literature, and I think that this is a little bit of the approach that a practitioner who is basically seeing patients and having to try to convince parents. I think that's the approach that practitioner should take, rather than the angry approach of picking up the phone, calling the ophthalmologist, and calling them unsophisticated, or not really knowing what they're doing. I think you have to take a much more sophisticated kind of approach and an educational approach with them.
Okay, that actually is a really good segue into my next question. So as a local OD, maybe trying to build up their Ortho-k practice, and perhaps one place that you might go is for referrals. So if you want to reach out to a local ophthalmologist, maybe a cornea doc or a LASIK surgeon, maybe patients go there to be evaluated, but they're marginal candidates, so maybe Ortho-k could be a good option for them. If LASIK wasn't the deal, I'm talking about obviously for older patients. What's the best way to kind of go about meeting with an ophthalmologist? What do you recommend? Do you bring studies? Do you bring papers? Do you try to book a lunch? What's the best way for a doc to kind of get in with another doc?
Well, I'm glad you asked that, because an interesting story about 5 or 6 years ago, I was on the program for the general scientific session at the Vision by Design meeting. And something came up at the last minute. I had to go out of the country to do an important teaching event. So what I did for that program, instead of showing up in person, was to interview one of my local active pediatricians and one of my young and local clinically active pediatric ophthalmologists. And it was kind of interesting, the two different approaches they had. And this is going to change depending on the various different practitioners that you talk to. But these two people, the pediatrician was happy with the introduction of a concept by a telephone call and then a follow-up with some written materials that the pediatrician could understand in terms of orthokeratology or myopia. The pediatric ophthalmologist liked to have an in-person discussion with having the scientific papers sent beforehand so that that discussion would be more fruitful. But she liked an in-person kind of meeting. The pediatrician, that individual was happy just talking over the phone and getting the written material. So what I guess I'm saying is that there is no one answer of approach. If a breakfast meeting or a luncheon meeting is kind of what the other party wants to do and you're good at that, then by all means go for it. But if on the other hand, you get the feeling that this person is extremely busy, running their tail off, would prefer just to have some written material sent and a follow-up telephone call, then go ahead and do that approach. So I think there are a variety of ways in which to, get to the goal, and that is to do your best to discuss this. But do discuss it, and don't just leave it as hard feelings, as why does the person down the block not talk to me? Will you get certain ophthalmologists that just don't have the time, or don't have the personality to talk with you? For sure. But I will say that nowadays that would be a silly ophthalmologist. Most ophthalmologists need the support of the other eye care practitioners out there in the field. They need the referrals. The competition's pretty intense. So why would I not talk with my optometrist down the street, who, for example, could send me LASIK patients that they might see, or have this interaction so that I can help them and they can help me.
Yeah, that's a really good point. And we should be doing the same with our OD brothers and sisters as well, because there's no rule against OD referrals. So I would encourage people to go out to your local docs and have conversations in a similar fashion. It doesn't have to be ophthalmologist to optometrist. It can be, there's plenty of patients to go around.
Well, I think that's true. And in fact, I have to do the reverse. I have to figure out ways in which to talk about myopia control with the optometry group out in my community who is not doing myopia control, so that I can see the patients that I need to create a program. Because in ophthalmology, we generally don't see children. So if I'm going to see children at the age of 7, 8, 9, 10, I really need to reach out to my optometric colleagues and other eye care practitioners to help me get the message across, and which means that I've got to do everything in reverse from what I just said that perhaps the OD has to do in terms of contacting the pediatric ophthalmologist. And so I have to figure out and be creative on how to get into the OD's office, because they're just as busy, if not more busy, than I might be.
Sure. Yeah, it's a good point. Do you feel that have you seen a change? You've been doing this for a long time. Do you see a change in the breed of ophthalmologists? The new breed, if you will. The young docs coming out of school. Are they much more excited about new technologies, new things? I'm not necessarily comparing to surgery, because to surgeons there's nothing more exciting than surgery, but are the new ophthalmologists graduating with an understanding of myopia, the dangers of myopia, and are they interested in finding new strategies and ways of dealing with it?
I would say yes and no to that question. Yes, in the sense that if they have their eyes and ears open and a little bit of interest in this particular field, there's certainly now more and more papers being written on the Academy's iNet magazine, for example. The American Academy of Ophthalmology has a special myopia committee that's involved in tracking the myopia epidemic. CLEO has put on, or Eye and Contact Lens Association, put on numerous symposia. But the training ophthalmologist has to really have some particular interest. Most of them are so inundated with emergencies and emergency surgeries, or the ulcers that they see in emergency rooms, maybe 80% of which is due to contact lenses, that they are maybe not getting the message. And I would say that may be the majority of ophthalmologists. Ophthalmologists in their training programs would be very lucky if they see or hear much about contact lenses. It's just not, they need to have some knowledge about that because it's on our boards. But normally the programs are not very intense in contact lensology. So when they get out, they're prime excellent targets for us to go to and say, I've got this particular program. I think it would be interest to you. We're very sophisticated in doing myopia control. Please listen to my story and please refer. And I think as the myopic epidemic becomes more obvious and it's stuck right in their face and they can't deny it, they will probably begin to respond.
So the myopia concern, is it indeed growing in the ophthalmology sphere? It sounds like it is.
It is, and I think probably what we're going to see with the majority of ophthalmologists, because they're not sophisticated in contact lenses, will be the use of pharmaceuticals, will be the use of atropine, or maybe they're sophisticated enough to get into bifocal contact lenses or progressive peripheral add lenses. I don't anticipate many of them will be jumping into orthokeratology unless they did what I did, and that is to have some kind of joint symbiotic relationship within my practice with a good fitter who I could work with and who could do the hands-on work that was necessary.
Mm-hmm. Yeah, it's really a fascinating topic, isn't it? Just every journal you open up nowadays seems to at least have one article or update on myopia. So atropine, when you talk pharmaceutical, obviously, at least in this country, we're talking atropine. There's greater acceptance to it in the world of ophthalmology, and it's being utilized as a safe, way of trying to slow down the progression rates, as far as you've seen.
I think that is a true statement. I have been tracking some of the pediatric ophthalmology meetings since I was asked about 3 years ago to talk about Ortho-k in the Pediatric Ophthalmology Subspecialty Day at the American Academy meeting. A lot of the different groups will have a whole day in front of the meeting to do their subspecialty conferences. So I thought it was perhaps a first step at that time to see about an hour-and-a-half symposium on myopia. Subsequently, I have noted that they have continued to do this on a yearly basis with more and more sophistication and more time devoted to it. So if the pediatric ophthalmologists are starting to get involved, that gets in the literature, that gets to some of the general ophthalmologists, and we're definitely seeing changes. So I don't think ophthalmology will be so much in the dark when their local eye care practitioners go and talk with them about myopia control.
Would you maybe spend a couple of minutes talking about axial length and what your thoughts are about the importance of measuring that, as serial measurements, especially as a myopia control expert?
Sure. I think I agree with most other people doing serious myopic control. How am I going to know whether I'm controlling axial length? Is cycloplegic refraction good enough? Well, it turns out that most ophthalmology offices, because we measure axial length for cataract surgery in terms of putting it into our formulas to come up with the power of the intraocular lens, we have the very best machines available to us usually in either the OrbScan or the LensStar. I have the LensStar in my office, and we're very, very concerned about getting very accurate readings because we don't want to be off in our intraocular lens implantation powers. So for me to do, and these are non-contact instruments, so you can do it with children pretty easily, and it doesn't take very long to get a measurement. So we can get very accurate measurements to probably a couple of hundredths of a millimeter in terms of axial length. So I am resting assured when I'm getting good axial length measurements, and I know exactly where I stand. So we measure 6 months down the line, and certainly then either 6 months or yearly, depending on how stable the child is and their refraction. But we do like to get axial length measurements.
Yeah, I agree. And I have to say, in addition to, at least from my own perspective, in addition to seeing progression rates with axial length, to me, it also helps me assess risk. If I have maybe a 10 or 11-year-old, despite what their myopia might be, with an axial length of 26 or 25 and a half or 26 millimeters, I'm nervous because that's already a pretty big eye. So I might treat that a little differently than that same kid with a 23.5. I don't know if you feel the same way, but to me, it's helping me assess risk.
I have to agree with you. After years and years of doing cataract surgery and measurements, when I get a 26 millimeter eye, I'm dealing with somebody who's a -6, 7, 8 already. And, because our average readings are usually in the 22, 23, maybe 24 millimeter category. So there's something going on that's not right, or different when you get a 26 millimeter eye. Now, we also have had eyes that go beyond 30 millimeters, and those people are wildly nearsighted. And, we even get to a point where we don't even have to put in an intraocular lens because there's no power needed. The eye is so long.
Now, that's an incredible thing.
And we certainly see that regularly in keratoconus patients, where because of the corneal curvature taking over so much of the power curve. So, I think you're absolutely right to be nervous if you got a kid who's 26 and you're not measuring that myopia, meaning that you're getting a cycloplegic thing of -1, or that just doesn't go along. It usually is very, very mathematical as to how much the degree of myopia is to the axial length of the eye, considering that the K readings are within normal limits.
Yeah, right, exactly. So, any sort of, as we kind of wrap things up here, any concluding statements, things that are on your mind, things you want to share with the audience?
Well, yes. Having been on the board of the AOMC and the International Academy of Myopia Control, and having spent a lot of time with my optometric colleagues, I know that there periodically becomes times where we don't regularly talk to each other, and we need to do that. We need to, get the time periods when everybody is, talking and working together, and bring up without any embarrassment at all our myopia discussion, and have a frank discussion, bring the literature to them, show the changing trends even in ophthalmology circles, and basically try to make it happen, because what we're dealing with is Carrie Hertzberg has taught me, is we're not doing our own battles, we're battling for the children, and we're working on making sure that we're doing the right thing and trying our best to give the information not only to parents but to our other eye care professionals who aren't so involved, and make sure the child gets what that child needs. And certainly we all need to kind of work together closer and closer, and I've been very, very happy to have the opportunity to do that, particularly sitting on different boards of different organizations.
Well, it's been terrific and enriching for me professionally to have gotten to know you and work with you on our board, because you offer such a different perspective on things, but yet it just reinforces what I've always thought, which is, you know, we're a team, and this is a team approach. And one little, you know, about an inch, you know, long eyeball really requires a lot of care, and it requires a lot of different specialties to do it right. So, you know, to your point, we got to keep talking and keep making more friends, and never assume that our colleagues know what we know. You know, so there's always an opportunity to learn, and by the same token, we can learn by listening to our colleagues. So I definitely appreciate the sentiment.
Well, and I appreciate having this opportunity to, frankly, you know, talk about the issue of myopia, myopia control, orthokeratology, Paul. It's, you know, getting this message out, I hope will be helpful.
Yeah, I think it will be. So again, I want to just thank you so much for taking the time to join us. Matt, would you like to jump back in? Sorry, we kind of just stole the show here.
No, that's fine. That's what I wanted. You know, we talked about, you know, getting Bruce on the show, and I said, you know, just you take the reins, and it was a great conversation. I learned a lot myself, and you know, I talked to a lot of optometrists. Some of them work for ophthalmologists, and if this can help any of them have that conversation about bringing Ortho-k into that part of the practice, then this would be a very beneficial thing to have. So thank you both for coming on the podcast, and for the audience, we'll see you with we'll have you back on the next episode. So gentlemen, thank you.
Thank you.
Thank you.